Good evening, everyone, and welcome to our TIF Talk today. We're very excited to have two special guests today, two physicians from West Virginia at Marshall Health. We have Dr. Wissam Franda. Welcome and thank you for being here. And we also have Dr. Ahmed Sherif. So thank you for being here. Just so you guys know, I am Andrea Millers and I'm with Endogastric Solutions. And we're very happy to have you here today. If at any time you have any questions during this live event, please feel free to type your questions for the physicians on the chat box to the left, or the comment box, if you will. And we will do our best to answer any and all of the questions that you may have today. So a little bit more about our special guests. We have Dr. Franda. He is a practicing gastroenterologist and assistant professor at Marshall Health, again, here in West Virginia. He received his medical degree from Al-Fateh University School of Medicine and completed his residency at Texas Tech University Health Sciences Center in Lubbock. His fellowship in gastroenterology and hepatology was completed at the University of Kentucky in Lexington, and an additional fellowship in Advanced Endoscopy was completed by Dr. Frandah at the Center for Interventional Endoscopy in Orlando, Florida. Dr. Frandah also has extensive training in diverse endoscopic procedures, and he specializes in gastroenterology, complex interventional endoscopy, and advanced therapeutic procedures. Thank you so much for being here with us today, Dr. Frandah. We really appreciate it.
Pleasure.
We also have Dr. Ahmed Sherif. Dr. Sherif is a gastroenterologist as well as section chief of gastroenterology and associate professor at Marshall Health. Dr. Sherif received his medical degree from Al-Fateh University School of Medicine and completed his residency at Albert Einstein College of Medicine in New York City. His gastroenterology fellowship was completed at the University of Michigan in Ann Arbor. Dr. Sherif has extensive training in all general endoscopic procedures as well as advanced therapeutic endoscopy. Thank you so much for being here, Dr. Sherif, and welcome.
Thank you very much. Pleasure of mine.
So we're very excited to talk about GERD and acid reflux today, and also the TIF procedure, obviously. So we're going to go ahead and start with Dr. Sherif. I know you want to discuss a little bit more about what GERD is and acid reflux, and also talk a little bit more about managing your GERD and acid reflux.
So gastroesophageal reflux disease is it's one of the most common diseases in the United States. It's actually, the expense on this disease is past $1 billion, and from workup to medications. And I want to liberate the GERD disease. It is reflect the first word of each, first letter of each word, like gastroesophageal reflux disease, and that's what stands for GERD. And it is basically simply is the reflux of the food content in the stomach into the esophagus, and that can lead to a variety of symptoms. Usually, the reflux, there is a physiological reflux, which is certain number of days or certain times per day, and that's usually normal. But when it's for an extended time, it would lead to pathological effect. And it can be from a simple, typical heartburn symptom to go to severe esophagitis, which is inflammation of the lower esophagus, to a stricture to the lower esophagus. Also, we know as a long term of acid reflux or non-acid reflux lead to changes in the lower esophageal mucosa, which can lead to conditions, we call it the Barrett's esophagus. And in certain group of people, usually in white men above 40 who have other cofactor, will be a risk for esophageal cancer. And that can be added more factors with smoking and etc. And reflux can be also a typical picture. There's many people actually asymptomatic with reflux, or they can present it with a typical picture in which they have like a throat symptoms, which is like laryngitis or change in voice, or like we deal with our colleagues like in the ENT, they will bring after they do their workup and they think it is GERD. And as well as can go with some people have a chronic cough unexplained by the pulmonologist or the doctor who's dealing with the lungs, or with wheezing, or people with asthma, a clinical picture in which they are really diagnosed with asthma and it turned out to be really secondary to reflux, or it can be devastating in which people get admitted to respiration pneumonia, and that's due to a significant reflux. Reflux, what bring this disease on? I mean, many people will say, or studies said, there is an idiopathic etiology. We don't know really why it happened. Genetically, maybe there's a weaker sphincter from one people or one group to another. But there is also things affect the lower esophageal sphincter. And that, which we like to call it kind of the lower, the gastroesophageal valve. Many elements is there, including the lower esophageal itself, the diaphragmatic crura, the angle of his. There is the phrenoesophageal ligament, and when there is effect in this area, anatomically become the barrier is gone. In which, for an example, like in a hiatal hernia, that kind of promote the reflux. Or lead to a reflux. And I like to simply explain it that when you have all these structures and you go like the lower esophageal sphincter is a weak sphincter by itself. And the diaphragm, the diaphragmatic crura is also a weak sphincter by itself. When they are in the same level, they act synergistically and they can prevent the pathological reflux. But in an example of a hiatal hernia in which part of the stomach slid up, the two sphincters are not in the same level. Each one will act weak, and that can lead to the pathological reflux. There is some data said not everybody who have a hernia will have a reflux. It's true, but it is more opposing to the pathological reflux. Other factors lead to reflux. Aging by itself, as there is some weakness of the musculature, can lead to the weak of this valve. There is physiological, like in pregnancy women with, or even obesity or anything increased intra-abdominal pressure can lead to that reflux. Also, we can see that in people who in certain sport like injury or lifting weights can lead to developing of these promote to get to defect in the gastroesophageal valve and will lead to pathological reflux. There is also other factors, hormonal factors. Some hormones can decrease the lower esophageal sphincter pressure. There is, if you look at also certain medications can play a role in that. Food itself, people who eat protein to diet, these people have actually the lower esophageal sphincter pressure is high and they are protected more than people who are on a high fat food and they will lower their esophageal sphincter. People who use chocolate or peppermint, these will lower the esophageal sphincter pressure and will lead to the pathological reflux. Of course, medication, as I mentioned, can play a lot of role in that one. GERD is usually presented first to the primary care physician. And that's where the primary management of GERD happened. And usually we'd like to take it like a step up in which there will be a life change before we throw any medications and confirm the diagnosis. Is it a GERD or not? And basically, we recommend people, if they are obese or heavy setting, or really doesn't have, to kind of lose weight, exercise is documented to help with GERD symptoms. To eat in a posture of upright and not to lay down for at least 3 hours, it helps with these GERD symptoms. To eat small meals, because big meals will increase the size of the stomach and the pressure and increase the reflex. To stay away from the things lower esophageal sphincter muscle, like caffeine, like chocolate, like fat. Also to decrease the drinking of citrus fluid or drinks. Sodas is really known to kind of predisposing factor. Smoking is a big factor in GERD, so alcohol. So we do all these life changes, and then we could add, or the primary care add certain simple over-the-counter antiacid medications, simple cytoprotection like Carafate or then we go after that to the kind of more potent proton pump inhibitor. Now we have it in a low doses over the counter if they can get away with it, and then high dose. But now there is a shift because we found we know there is a lot of side effect of these medication for very long term. Right. And I think that is where the management is start being changing when after this failed by at response to the primary, then it will be shifted to a gastroenterologist, and then there will be a different options. I might actually let my partner elaborate that on it if he.
Yeah, wonderful. Thank you for that explanation. That was very thorough. We do have a couple of questions in regards to GERD and so I might ask you a couple of those before we move on, if you don't mind. We have a question from Dawn. She's asking, if I have chest pain, how can I tell if it's GERD or a heart problem?
Oh, we look at first when patient present to primary care with chest pain. We have to be sure it is not related to these, and that's the first thing. Story is important, but we run EKG, we run symptoms, we look at comorbidities. And once we rule out the cause of chest pain is from the heart, then it comes the workup of the gastroenterologist. And one of the things, we have a couple of testings. We do 24-hour pH, and also we do esophageal motility studies. Simply, these two clinically we can do them. Also, we like to do endoscopy to see what's the status of the esophagus. And by itself, that one can diagnose if it is secondary to the GERD inducing erosive esophagitis. There is other studies you can do, like an upper GI swallowing study, which is simple drinking barium and looking at an X-ray, and can give you more about the anatomical. And we use this in people who we decide to do endoscopic therapy. We use this as a workup for them.
Okay, wonderful. Thank you. We have another question in regards to GERD symptoms. Can it burn your throat and sinus from burping constantly?
Yes, it can. And I want to elaborate about it. This is more with the acid reflux. And I'd like to mention, yes, it can. And that's when I said it presented with a typical presentation. And patient didn't have the heartburn, but they really have the change of voice or throat or laryngitis and sinusitis. I'd like to mention also, many people have the concept of GERD is only acid reflux. And sometimes you have these people treated with anti-acid medications, and they don't respond. In fact, I want to mention that GERD is not only acid reflux. There is acid reflux and there is non-acid reflux. And the non-acid reflux tend to not respond. Maybe respond a little bit by cutting the volume of the acid secretion, but the fluid will reflux and can lead to certain people have a lot of symptoms. So that's where we do the workup to differentiate if it is acid reflux versus non-acid reflux versus esophageal hypersensitivity. So there is a workup to be done to determine which patient will respond or not.
Perfect. Thank you. Do you want to talk about the workup now? What you guys normally do for patients, or is it dependent on each patient? What do you what are the types of tests that a patient could potentially undergo? EGD, are they going to have the pH testing? Or do you do that for everybody, or how do you guys go about that?
First, when these patients present, it depends on the symptoms.
Sure.
And you cannot have really it's each story have a workup. If a patient who is his predominant symptoms is only heartburn, and if he is a young age and his symptoms is not very strong, sometimes it's good to do conservative therapy and try the non-invasive approach. If a patient who is a white male above 40 with significant symptoms, you like to do an endoscopy because you want to know, does he have an advanced esophageal disease from like erosive esophagitis or Barrett esophagus? So age can make a difference, gender can make a difference, coexistent symptoms can make a difference. If it's only a chest pain, EGD sometimes we add motility study. You can do the EGD. If you find evidence of esophagitis on an EGD, then you don't need to do the 4-hour pH because you already documented there is a damage from it. And you just do the motility study if you decide to where we go and is it the chest pain is because of this esophageal motility abnormality secondary to GERD or secondary to something else. And upper GI, usually we do it in a little bit more advanced, in which if we decide to do surgical or endoscopic therapy.
Okay, wonderful, thank you. So let's go ahead and start talking about available treatment options right now for GERD. Obviously, I know Dr. Sherif or Franda, you're going to talk a little bit more about the TIF procedure. There's also questions about Nissan, and I have some questions too that have come up, but I'll let you kind of discuss and talk to us about what is the TIF procedure and what other treatment options do you guys normally offer for patients that are suffering.
Right. So when patients presented to our office with a GERD and they're asking for options after they've seen the primary care, or sometimes they come to us as a self-referral. The way I describe it to them, it's kind of like a spectrum. There is around probably 2/3 of majority of patients with GERD. They'll have very mild symptoms like once or twice a week, with once or twice a month at nighttime symptoms, and they'll just do PPI or proton pump inhibitor as suppressive medicine, taking it on a scheduled basis with some lifestyle modification like what Dr. Sherif elaborated on. And goes to the certain groups where it becomes the medication they'll be dependent on. And then whether they have an anatomical defect. And this, the way I say is there are two gates. So there is the internal gate, which is the G junction, and there is the external gate, which is the diaphragmatic crura. So if it's one or the other is weak, then medications only might not be the only option to help with the symptom. And that's where becomes the other options, including endoscopic or some approach based on the size of the hernia and how much is in the valve, we call it in the G junction, is it open too much or tight, like open intermittently at the time of the procedure when we do the evaluation. So in terms of surgery, the classic operation we have, it's called the Nissan fundoplication, and surgery has been there for almost 5 decades now. The operation, it's a good operation, but sometimes it's too good to do more than what's the effect supposed to occur in terms of suppressing the acid, but also that comes at the effect of people an ability to belch, inability to vomit, difficulty when tolerating diet several months after the operation. And that's what led to thinking about some other options for fundoplications.
Perfect. Wonderful. And you actually, we did a little pre-interview and you were telling me, so you guys have just recently moved to West Virginia. You used to both in Colorado, and you were talking about, doing the combined procedure with partnering with a surgeon. with a surgeon that was doing a lot of Nissens. And when you guys started doing the new procedure, he came back to you and said, because of the patient outcomes, he actually told you, we're not going to do Nissens anymore because the TIF patients are doing so well, right?
Right. Yeah. Yeah. So,
fantastic. Wonderful. Well, can you tell us or walk? I know you have a flip chart there that you can show us as well, but do you want to talk a little bit more about how the TIF procedure works and explain to our viewers how it works?
Yeah. So the terminology for TIF, it's a transoral incisionless, which means no incision, but that's only for patients who go for straight TIF. And then F stands for fundoplication. What is that entitled to? It's essentially a procedure will be done through the mouth with an endoscope, and the device, which goes on the scope, go through the device into the stomach, and then we'll just we'll wrap the stomach around the distal part of the esophagus. And the whole idea is to create a valve which is simulate the normal anatomy. So by that, we'll have less chance of having the dysphagia or difficulty swallowing, the less chance of having the post-procedure bloating, and they will able to vomit, or it's like when there is a burp, they will be able to do that in comparison to the surgical option. And this is what I was referring to. So if you see me clearly here, this is the esophagus, and then when it goes down, that's where is the G junction, we call it. That's the junction between the esophagus and stomach. Yeah.
Bring it a little bit closer. Yeah, there we go. That's perfect.
Yeah. Okay.
Yeah, now we can
see my finger there?
Yes.
Okay. Yeah, so that's where that just the part of the device where it mounts and it kind of flip almost 180 degree on the top of the stomach, and we'll just pull that part and wrap it around the esophagus. So, and usually we use something we call the fasteners, and these are not permanent. So they meant to have time for that area to heal, and then they'll dissolve. So we got a lot of questions about whether this is something is compatible with some MRIs. I'm okay if I go through an airport security, I'm gonna ring an alarm. So these are non-metals. So
wonderful, thank you. If you don't mind, we do have quite a few questions that have come up, so I'm gonna go ahead and try to get from our viewers. We have a question from Pam. She's asking, I've had the TIF and hiatal hernia repair procedure 5 weeks post-op following the food plan, but starting to have some reflux. Is that normal?
It's like, you know, the symptoms like after the TIF, like is this more of a heartburn or more of a chest discomfort? Because this can happen, especially with creating a new valve. And the part of it is because of just the healing process of the fundoplication. Now, however, if there is more reflux, so it feels like there is an sensation of throat like belching or that kind of water brushing or things like that. Then maybe the option is to maybe consider reevaluation after maybe a certain time, like usually after 6 to 8 weeks, we kind of reevaluate. And as we know, the part of the fundoplication works on the level of having, not everyone will be off the acid medicine, we know that, but that the thing is like it's almost 80+% of those population, so.
Yeah. Yeah, and possibly, how long do you normally have patients on PPIs after they have their TIF, or do you have them strictly off of them after their TIF?
So this is a good question. What I do is, what we do is, in general, after we start the procedure, they'll start on that special diet. And the diet by itself has a lot of things it's a part of lifestyle modifications. So there automatically will be less acid. And with the repair, so I'll let the patient, I'll tell them just as you need it. So if you feel you want to take the PPI, you continue to take it till you feel like, well, you're eating the diet that it's not used to bother you or give you problems and is not anymore, then you feel like you don't need it as much.
Okay, perfect. Thank you. We have a question from Mohammed. He's asking, if I had Nissan in the past and it is loose now, am I still a candidate for the TIF procedure?
The answer, it depends. That is because so when you after you get I'm assuming if you say it's loose, you had an endoscopy done and it shows that the wrap maybe it's not tight or is not working properly. If there's not much hiatal hernia there, then yes, it can be an option. But if the hernia is too big or there is some other condition we call slip wrap or twisted, then surgery might be needed. So.
Okay. Perfect. And then one more questions from Teresa. She's asking, PPI is not working, but the burping is burning sinus and throat. Does that mean it's low acid instead of high acid?
There is, this could be what I said, the non-acid reflux.
Right.
Which the PPI is not really working, and you're suppressing the acid, but you're not preventing the reflux. And these people will love to work them up. And that is, I think, endoscopic therapy like TIF will make a big difference for these patients. Yeah,
wonderful. Thank you. I wanted to go back. I thought the way that you explained the valves, the two valves, and the gates analogy was really profound. It just made it really easy to understand the two gates that you need to fix potentially when you have GERD and acid reflux. So you talked about the TIF procedure and how it works. Can you talk to us a little bit more about not just recovery, but pre and post-op? What can patients expect, just prior to coming in to have the surgery, and then also what can they expect? You touched a little bit about the diet, and then also, when can people return back to work after they had the TIF procedure? So if you can kind of just go over a little bit about the pre, post-op, or even the day of procedure and things to expect for these patients.
So after we do the workup, like we do start with the endoscopy, we know what do they have a hiatal hernia, what the size, and if they have an esophagitis and had a pH study, when we ruled out any major esophageal dysfunction like achalasia or things like that, then we consider this is the workup, and the patients tell us like, I cannot tolerate taking the acid medicine, or they've heard about the long-term side effects of those medications. Then we'll consider them based on the size of the hiatal hernia, whether they'll go for a combined procedure, which the hiatal hernia would be repaired laparoscopically and then do the fund duplication, or if they're candidate for going into the straight for incisionless fund duplication. It means purely endoscopic. So in terms of the diet, we usually have a pamphlet, and we just go, we tell the patients, we give it to them in the office when before they and tell them this is your grocery list, So just go get shopping for what you're gonna have. And then on the day of surgery, they'll just come in as an outpatient in the morning. Depends if they are combined or it's straight. We usually keep them an overnight in the hospital after the procedure. And just for the reason is to manage their nausea and possible vomiting and the post-operative sometimes discomfort. And then we'll just tell them that's the diet plan. So what Dr. Sherif is very, you want to tell them how to approach it with the patients about in terms of the diet and what phases you introduce.
I would like to add, first is I prefer to have the esophagitis, erosive esophagitis, controlled before we do the TIF. And usually I get them kind of heavy medical therapy with carapate and a PPI twice a day, if it is really erosive esophagitis, because kind of more successful to treat the GERD or the reflux when the mucosa is somehow healed instead of placing these fasteners in an active inflammation. And when I do that, basically, I really already put them on a very strict GERD diet and also maximize the medical therapy for them. Then after that, actually, I used EndoSolution, gave me a lot of good materials to help me navigate, because you cannot even, you tell the patients, remember it, I go over what I have. So I have very nice sheet I provided to the patient, and pretty much it is self-explanatory. And I like what he said. He goes and actually tell the patient, go and start shopping, because it tells you exactly in details you should buy and what you should take. And you can see, you pointed, the first 3 days is really the hardest day, in which we keep you only in clear liquid, probably low sugar. And then after that, we go for a full liquid, in which is a 14 days. And the people who are really compliant with this diet, they do a lot better. And I think if we do a really statistics for the people post-TIF diet compliance, they do a lot better. The people who really go and not get compliant, they kind of less doing better. And you see after that, from 3 to 4 weeks, we go low to soft diet, and then we go 5 and 6 weeks. And then after that, after 6 weeks, I told them, if you're doing everything, most of the patients I dealt, they go to regular food in 6, no restrictions. They even go back. I tried to tell them not go to high spicy and alcohol and orange juice, and just take it easy. And some of them did, and they went really asymptomatic. But I used to advise that to go, start drinking alcohol and start this.
Yeah.
I don't recommend it, but I have people really went to doing everything, and they didn't have any more symptoms. So
Wonderful.
So yes.
Yeah, wonderful. What about activities? We get lots of questions about patients. When can I go back to work? When can I, exercise and go back to normal after their TIF procedure? What do you normally tell your patients?
Yes. So the first few days after the observation overnight, and they go home. The first week after procedure, I would probably restrict the work activities. And important part for me is the weight. So don't lift anything heavy, more than 20 pounds or so, for the first 6 weeks. And that has a lot of things has to do with the valve, with the repair, and especially if they have a hiatal hernia also repair, because that might disrupt the crura, and we go back to ground zero. So again,
Right.
so yeah.
Perfect.
Yeah.
Okay, wonderful. We do have some more questions, so I'm going to go ahead and start asking some of these questions. From Shane, how long does the TIF procedure last? Can it be redone?
For now, if all the setting is correct and it is a naive TIF and straightforward, and there was not much more cofactors for patient GERD, my expectation will last long. But we TIF been around for many years, and if it is for some reason became or there is some recurrences, you always can strengthen the TIF by applying more strength of the valves, and you can do another endoscopic. I personally didn't have to do one for the last year or two. We didn't have to. But I'm expecting maybe Dr. Franda has longer in doing this than me, so maybe he can liberate his personal experience.
No, I don't have anybody I really do yet, but I think that the thing with the endoscopic fund application is you don't burn bridges. So what one of the things is we have data now. It's up to 5-year data out there, and it shows a good response. As we said, the PPI, there are 4 out of 5 patients that'll be off PPI. Their quality of life is significantly improved. Less regurgitation, which is there are a lot of factors very, 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 very encouraging. We don't have a longer data more than that, so it's because of just the nature of the procedure, how old it's been. But so those are really encouraging things. And again, this is a the procedures always can be redone. So in occurrence of reflux, you always can go back and strengthen the valve. Or if it becomes a point that the crura becomes loose and there's a hernia that cannot be repaired, then it's time for surgical repair in addition to the fundoplications.
One of the things we did this, the Marshall Heartburn Center, in which it is between gastroenterologists and the surgeons, we put a criteria for these patients and we decide which approach to go. But like what he mentioned, we see now, we are biased, but we've seen a lot of people, the Nissan fundoplication. After 2 years, they go back on a PPI, the wrap get looser faster, and we don't see that with TIF. And then when the surgeon goes and do the second wrap, it is very difficult because he different procedure and more suturing and fibrosis. But when you do a repeat TIF, you're just strengthening the valve. So it is easier to redo. Actually, now I think even for the people who has Nissan fundoplication and it's got loose or that, it's better to do TIF on them than to repeat and strengthen the Nissan fundoplication. And that's what we had with the experience working with the surgeons in Colorado.
Perfect. Wonderful. So we've got another question. What do you think about Reglan for long-term? And then I guess they're asking question, kidney issues. What do you...
Reglan is, where is Reglan play a role in people who has GERD? Like I said, people who eat heavy meal or people who are diabetic and have gastritis and the stomach is full of food, then that is increase the pressure and lead to a GERD. And that is Reglan will treat that gastroparesis, empty the stomach to prevent the fullness of the stomach, which indirectly prevent or improve the reflux. And that's where the Reglan help. Reglan is not a drug therapy for GERD, but it is help to empty the stomach to decrease the pressure in the stomach and indirectly will improve the reflux.
Perfect. Thank you. Another question, can you have, from Susan, can you have this surgery if you are considered obese?
Great question. So far with the data we have, our BMI, I'm gonna share it with my partner, especially in West Virginia, it's the most, I think, of the cases, they have a BMI of 35, correct me, but we went with the help of the surgeon to 38. Mm-hmm. But it is, we'll recommend some weight loss first. We'll help them. That's where we have the Heartburn Center. It's our surgeons are foregut surgeons. We could work with the sleeve to cut down. So we like to get the best outcome. And the data is not there for people of BMI 40 or higher. Maybe down the road will be more aggressive. But so far, I think I have to stick with the guidelines 35 or less. We can go straight to TIF. Above 35, we will have in the Heartburn Center other option to help with the TIF with assistant surgeries.
Perfect. Thank you. So a question from Bertha. She's asking, I do not get food coming up or burning in chest. She does get some hoarseness, hot feeling at night. Oh gosh, sorry. Okay. Upper endoscopy says Barrett's esophagus. I eat 3 hours before bed and I have the head of the bed up. I have irritable colon, mostly constipation. I think the heartburn is connected with the constipation. Could that be? Is there a treatment for Barrett's esophagus? It was a long one.
You want me to elaborate or you want to elaborate?
Elaborate on the Barrett's esophagus one. So,
all right.
So it's for treatment of Barrett. It depends on what was in the biopsy. There is a dysplasia, which means that their cells are precancers, or no dysplasia, because that will change what you need. of course, number one is you need to control the GERD, control the acid, because that might decrease the progression. And then for this, if it's a dysplasia, then there are options. It's doing an endoscopic therapy with ablation or freezing. We call it cryotherapy. Or then if there's no dysplasia, then we just kind of watch endoscopic surveillance to kind of make sure it doesn't progress to a cancer.
Okay, and she said, she added a comment, by the way, I'm 85. Am I past the age of having surgery for Barrett's or GERD?
I don't do age discrimination. I do health discrimination. A patient in a good health, the age, you can have somebody at 50 have a lot of comorbidities in which I will decline going forward, and I will have a patient who is an 85 healthy have a quality. If I could improve the quality of life, I will. And for TIF procedure, straightforward is not a major surgical like face high is doable in the right setting. But for the Barrett's esophagus, long segment of Barrett's, I tend to not do the TIF till I treat it, because God forbid this Barrett's have some dysplasia and change to a cancer, you can hide it when you build them with the TIF procedure. So you want to treat the Barrett's first, and we do ablation, treat it, document the normal mucosa came back, and then consider the patient for TIF procedure.
Perfect. Wonderful. Thank you. One more question from our viewers. We've got Derek. She's asking, could I do the links, or he's asking, sorry, could I do the links after a failed TIF? Hypothetically, I'm looking at both procedures.
I'll answer that question. I have a great exposure with links, and I have a conflict because I saw the outcome of links and I see the outcomes of TIF. And pretty much there is a center is they actually taken out more links than putting them in. And but TIF, I didn't see that. Now, might be an operator dependent variations, but I kind of next did some improvement with the magnet, but I feel, and this is a personal opinion, that TIF is way superior than the links, and I didn't see a failing TIF links. And if a TIF fail, it can be strengthening. And what is exactly the definition of failed TIF? That's what I want to know, because to explain what is failed. The valve, if it is built, then there's no point of placing anything else.
Right, right.
Do you have anything you want to add?
I think it's just that two different options, available there. So looking for links. Sometimes you want to present to the patient, or I tell them it's like, well, this is a device is going to be implemented in the GA junction, in so forth, or you have this fasteners. They'll be there a couple of weeks and they will dissolve. So there are certain indications. Some surgeons, they don't put links for patients who have any esophageal motility problems, because that's kind of big contraindication for it. TIF is not, so which is more appropriate, So it's a different depends on the patient, what their preference, what the right indication for. But personally, we've seen it, we've seen more links being coming out more than to put in. So.
Also, there is the presence of a hiatal hernia, very difficult to do, because it slips and it can have kind of downside effect to it.
Okay. Thank you. I appreciate that. It looks like you've got some fans from Colorado that are on watching. They say, that's my guy. We miss you here so much. From Lauren, I don't know, Coley, I think her late name is. So anyways, they wanted to say hi. But there is a question, where are you located now and where do you do procedures? So maybe tell us a little bit more about where you are, Marshall Health and the Heartburn Center there, and where exactly you're located.
We are really located in Huntingdon. It's in Huntingdon. It's kind of an area of a tri-state covering part of Ohio and part of eastern Kentucky, and it's kind of a widespread. And Marshall University is kind of, I think it's established in 1846. Hopefully, I have that date correct. So it has a long history, and administration here showed us really very big commitment to kind of advance the field we would love to advance, and appreciate it from Department of Medicine and the surgeon and administration in the hospital to build this heartburn center, which is we are working with the surgeon administration. It's kind of have from medical therapy to surgical therapy to the cases of obesity, because the foregut surgeons can do some bariatric as well, and we can trying to improve the health of these patients to endoscopic therapy. So it's done endoscopic therapy, and we advanced many other areas actually from kind of advanced EUS, ERCP. Marshall we really appreciated. They advanced the equipment, the facility. We are building a brand new facility, which will be hopefully ready in 2 years, which is a big facility, $47 million. And we are looking forward to kind of take this to the next level and make a difference in these people in the community. And also, I don't want to forget about Endogastric Solutions. They helped us kind of part of developing.
Wonderful. Thank you. Thank you very much. So we're getting close to the hour. Is there? I'm getting a sign saying we do need to say happy birthday to Dr. Frandaz. So it's his birthday today. I don't think he knew we were going to say happy birthday to him. We would sing, but I don't want to embarrass you anymore. But happy birthday to you, and I appreciate you. I appreciate both of you being on, and especially on your birthday for doing this with us today. Is there any last thoughts or last topics one thing I did want to discuss. I mean, I don't know if you're watching, you'll notice at the bottom that both doctors are together in one room. They did want to make sure that you guys knew that they did get COVID testing, and they're both negative, and hence the reason why they're in the room together. But normally they would have masks. Talking about COVID a little bit, maybe you want to kind of put at ease some patients that are potentially looking to, either get their diagnostics or come in and to even have a initial consult with you, or even have the TIF procedure, or any other procedures. Can you talk a little bit about the safety precautions and things that you guys are doing to ensure that there's the patients that come in are safe and safe to come see you?
With the help of internal medicine and the whole hospital, Marshall implemented strict rules in which we provide service, but in a safe environment. We have like sanitizers, masking, social distance, and patient had their staff. If there is any question about any staff sickness, they get quarantined. So it is really a very safe environment. And then everybody who is going to go for the procedure get tested within 10 days, doesn't go till he's tested. And then when he's tested, he's quarantined and come in for the procedure or the workup in the hospital. And all the staffs over there wearing masks, sanitizing, rooms are cleaned. So we are really following. And our incidents here comparing to the rest of the country where we were, it is very good statistics. So we are working normal with all these precautions.
Good. Wonderful. Thank you. Okay, so now any last comments or any last thoughts that you want to leave with people that are watching tonight?
I don't have any more comments.
Just tell them if you have a GERD symptoms and have a heartburn and taking medications and it's not working, you can ask call and schedule for a visit with because there are more options available, and really would be very helpful. And that a lot of patients are changing their lives after those then type of interventions.
I would like also to add for the younger people, if they are really diagnosed with GERD, this to me is more critical because you look in either you have an intervention with endoscopy and then you don't have to be on the medications because you're looking at to be 40, 50 years on medications. As we know, proton pump inhibitor or suppressing the acid that long can lead to a devastating side effect, especially in women with calcium or iron deficiency, hip fractures. There's stories about dementia. There's things. So acid, we need it. Acid, when you suppress the acid too much, it's your first defense against bacterial infections. So you need the acid, but you just want to prevent the reflux. And that is, I prefer the endoscopic therapy, especially when you look at you have a head of life in front of you. I think intervention will be better than medical therapy.
Perfect. Perfectly said by both of you. So we really appreciate it. If you guys are, if those of you that are watching are in the West Virginia area near Marshall University or Marshall Health, you can definitely give Dr. Frandah and Dr. Sherif a call. Schedule yourself an initial consult. If you are not in the area, you can visit gerdhelp.com. On there is a physician finder. You can put your zip code and or your state, and you'll be able to find a doctor that's located near you that does the TIF procedure. So again, Dr. Sherif, Dr. Frandah, we can't thank you both enough for joining us this evening. We really appreciate it. Now you can go celebrate, Dr. Frandah. Go celebrate your birthday. Have a nice dinner or something. But again, we really appreciate it. And Endogastric Solutions appreciates you being on here tonight. And I'm sure the patients and people watching appreciate it as well. So thank you, everybody, for joining us tonight. We have another TIF Talk coming up every Tuesday, so please feel free to join us when you can. Have a great night and stay safe. Thank you.
Thank you. Thanks. Good night.